Greetings, this is our presentation on narcolepsy. Today we'll be covering an introduction to what narcolepsy is, background and history information, characteristics and symptoms, causes, treatments, a day in the life of somebody who suffers from it, summary, and conclusion. Narcolepsy, put simply, is a chronic neurological sleeping disorder, or wake-sleep disorder, much like insomnia or hyposomnolence. Narcolepsy is often associated with daytime sleepiness and random uncontrollable instances of sudden sleeping occurring in opportune times. It is also associated with its symptoms of cataplexy, which will be discussed later on in the presentation. These symptoms, along with others associated with the disorder, can provide social, personal, and professional hindrance. There is no specific treatment or cure for narcolepsy, though a combination of medications and behavioral therapy can aid in controlling its symptoms. Narcolepsy was originally thought to be a genetic disorder. However, though, some families may have multiple cases of this unfortunate sleeping phenomenon throughout its members. This disorder was found to be more than just genetic. Narcolepsy has also recorded findings in being present in dogs and mice. This has aided performing research to discover more about it as it is simply an autosomal recessive order in canines, such as Dobermans, to further study the potential for genetics for narcolepsy and the genes in which it is located. Episodes of sleeping attacks and cataplexy can range from embarrassing situations, like falling asleep in the middle of a conversation, or dangerous ones, like muscle weakness and collapsing while crossing the road or sleeping while driving. This is a timeline highlighting the key events of history of narcolepsy as it was discovered, studied, and researched. Some highlights of this table. At the top, we have the first true description of narcolepsy, which was reported in 1877 by Carl Westphal, a German psychiatrist. He described not only episodes of cataplexy in terms of the involvement of a loss of muscle tone without a loss of consciousness, but also mentioned bouts of sleeping attacks lengthening the episodes. In 1880, another psychiatrist, Jean-Baptiste, had a patient with frequent sleep attacks, up to 200 daily. In fact, his patient couldn't go 30 minutes without falling asleep and required someone to wake him to go about his daily activities. He is attributed to giving narcolepsy its name, from which he derived the Greek words narcos, meaning somnolence, and lepsy, meaning seized. Lowenfield was the first to give the name to cataplexy, referring to episodes as cataplectic spells, in 1902. In 1983, it was discovered that those with narcolepsy are positively tested for HLA-DR2 allele. This was the first confirmed by multiple other researchers in various countries. Then, in 1998, the peptide hypocretins 1 and 2, as well as orexins A and B, which were then later found to be the same, were discovered in the hypothalamus. These peptides are directly involved with serotonin levels, which in turn controls wakefulness, arousal, and appetite. Later discoveries in 1999 and 2000 associated a deficiency of hypocretins and orexins in those with narcolepsy. Excessive daytime sleepiness. People with narcolepsy fall asleep without warning, anywhere, anytime. For example, they may suddenly nod off while working or talking with friends. They may sleep for a few minutes or up to a half hour before awakening and feeling refreshed. But eventually you fall asleep again. Excessive daytime sleepiness is the first symptom to appear and is often the most troublesome, making it difficult for you to concentrate fully and function. Sudden loss of muscle tone. This condition, called cataplexy, can cause a number of physical changes, from slurred speech to complete weakness of most muscles. It may last for a few seconds or up to a few minutes. Cataplexy is uncontrollable and is triggered by intense emotions, usually positive ones such as laughter or excitement. but sometimes fear, surprise, or anger. For example, a person's head may drop uncontrollably, or your knees may suddenly buckle when you laugh. Some people with narcolepsy experience only 1 or 2 episodes of cataplexy a year, while others have numerous episodes daily. Not everyone with narcolepsy experiences cataplexy. Sleep paralysis. People with narcolepsy often experience a temporary inability to move or speak while falling asleep or upon waking. These episodes are usually brief, lasting a few seconds or minutes, but can be frightening, because a person may be semi-awake when they begin dreaming and experience dreams as reality. Narcolepsy is a chronic neurodegenerative disease caused by a deficiency of orexin-producing neurons in the lateral hypothalamus. It is clinically characterized by excessive daytime sleepiness and by intrusions into wakefulness of physiological aspects of rapid eye movement such as cataplexy, sleep paralysis, and hypnagogic hallucinations. Facts have now established that narcolepsy is caused by a selective loss of orexin signaling in the brain. However, loss of orexin signaling might not be due to a simple genetic abnormality, as narcolepsy is most of the case acquired during young adulthood, and the vast majority of people with narcolepsy do not have mutations of the genes encoding the orexin peptides, or their OX1 or OX2 receptors. Loss of orexin signal is most likely not a simple failure in producing orexin peptides alone. Medications are prescribed to control some of the symptoms associated with the very serious cataplexy and also work to lessen hallucinations, sleep paralysis, and disrupted nighttime sleep. Some of these drugs include atomoxetine, clomipramine, sertraline, sodium oxybate. Risks of these drugs are mainly concerned with women during pregnancy. However, there are inadequate studies done on humans. Most often, doctors will prescribe a central nervous system alerting agent, commonly modafinil, along with other stimulants similar to amphetamines such as methylphenidate. Methylphenidate is used to lessen excessive daytime sleepiness. Some other notable medications to control sleepiness include armodafinil and dextroamphetamine or dexedrine. Some of the commonly prescribed drugs have high abuse and dependency potential. Narcolepsy requires the individual to change many aspects of their life in order to improve outcomes of management. Persons with narcolepsy are recommended to have a strict sleep schedule, sleeping and waking at the same time every day, limiting caffeine and alcohol consumption, especially near sleeping hours. Avoid eating large and heavy meals before sleeping, no smoking, ensuring a comfortable sleeping environment, soft sheets, proper mattress, warm room temperature. Relaxing before sleeping, taking a bath, reading a book. Exercise is also a recommendation for daily, which will help to reduce weight gain. Some alternative therapies such as meditation, herbal remedies, acupuncture, and massage therapy can be used in accompanying to the medications and behavior adaptations. Of course, it is always recommended to consult a physician and/or specialist before engaging in any type of treatment. With excessive daytime sleepiness, cataplexy, sudden loss of muscle tone, hypnagogic hallucinations, sensory events that occur at the transition from wakefulness to sleep, and sleep paralysis, inability to perform movements upon wakening or sleep onset, and nocturnal sleep disruption being common characteristics of narcolepsy. This study focused on methods of treating all of these disorders. As these symptoms are often disabling, most patients need lifelong treatment. The treatment of narcolepsy traditionally uses amphetamine-like stimulants to improve excessive daytime sleepiness and sleep attacks, whereas tricyclic antidepressants have been used as anti-cataplectics. However, treatments have evolved to more tolerable compounds such as modafinil or armodafinil. In addition, nighttime administration of a short-acting sedative, C-hydroxybutyrate, sodium oxybate, has been used for the treatment of excessive daytime sleepiness and cataplexy. These therapies are almost always needed in combination with non-pharmacologic treatments such as behavior modification. A series of new drugs is currently being tested in animals and in humans. These include a wide variety of hypocretin agonists, melanin concentrating hormone receptor antagonists, antigen-specific immunopharmacology, and histamine H3 receptor antagonist inverse agonists, which have been proposed for specific therapeutic applications, including the treatment of Alzheimer's disease, attention deficit hyperactivity disorder, epilepsy, and more recently, narcolepsy. This study concludes that current treatment is strictly symptomatic, and based on the present state of knowledge of the pathophysiology of narcolepsy, it is expected that more pathophysiology-based treatments will be available in the near future. Here is an example of narcolepsy stigma in the media from The Simpsons.
I'm sleeping all for a while. Look at these vacation photos. Oh my. Man, you people sure take a lot of vacation. That's just to remind you where I'm at. I think I have an idea what might be going on. First, you're going to need a spinal tap. Please be the bed. Please be the bed. Stop. Aren't you supposed to give him anesthetic? Oh,